Hello and welcome to this special podcast detailing all the latest in the care of paediatric lupus. I'm Ed Vital from the University of Leeds and I'm the chair of the Lupus Forum. So you'll have heard us cover all the new data about adults with lupus over the past couple of years, but something we haven't really done before is focus specifically on this crucially important subject of lupus in children. So I'm delighted to be joined by my colleague, Dr. Eve Smith, who's a paediatric rheumatologist and a senior clinical fellow at the University of Liverpool. Hi, Eve.
Thanks a lot, Ed. So thanks for inviting me to join in with the Lupus Forum and produce this podcast. So today we're going to talk about treat target in childhood lupus specifically, and whether or not this could be a realistic approach to care for children with lupus. To start with, we're just going to talk through a bit about childhood lupus and how this differs from adults with lupus to give a bit more understanding to the audience about that. So childhood lupus is rare, so it's rarer than lupus as a whole. It's chronic, autoimmune, inflammatory disease, and it's associated with significant morbidity and end-stage organ damage. And as in adults, the presentation is really quite variable. There's no specific diagnostic criteria. And of all patients out there with lupus, about 10 to 20% will have onset in childhood, so below the age of 18. And looking at the incidence, we've done some studies in the UK itself, a British Paediatric Surveillance Unit study showing that the incidence of childhood lupus is between 0.36 to 0.46 per 100,000. So far rarer than adult rheumatologists will recognise from their own practice. Okay, so in terms of burden of the disease, childhood lupus is known to be associated with significantly lower health-related quality of life, particularly compared to their peers. We know that patients develop damage early in the disease. So as part of that British Paediatric Surveillance Unit study that we did looking at the incidence of lupus, we actually went back to all paediatricians who had made a new diagnosis of lupus. This is a study that was run a couple of years ago, and asked them specifically about damage, and identified that about 20% of new patients had developed damage within a year, as defined by the SLIC damage index. So this is something that we've been particularly concerned and preoccupied about. And obviously children have a far longer disease course, so they have more time and potential to develop complications from the disease itself and also from the treatment. In studies that have compared children and adults with lupus, we know that children tend to have higher disease activity. They tend to have a higher medication burden, particularly in relation to corticosteroids, and they tend to have more severe areas of organ manifestations, so renal, cardiovascular, hematological, neuropsychiatric, and potentially combinations of these. And this is associated with higher standardized mortality ratios, so between 3- and 6-fold higher in children than in adults. With the younger you are, the higher the standardized mortality ratio. And all this is known to have longer term effects on physical functioning, psychological function, and also social outcomes. So one of the main studies looking at longer term outcomes is a study called the CHILL-NL study from the Netherlands, run by Sylvia Campus. And this has looked at outcomes at around 20 years post a diagnosis in children. So still not that long, and there's definitely a lot more work to be done in this area. But even, at that time point, they demonstrated a high impact on academic achievements, employment, and things like the ability to work full-time versus part-time, that type of thing.
Yeah, so I really noticed that, that the younger my patients are, even within the adult spectrum at time of diagnosis, is something I really note as a kind of, this is going to be more severe, one of my predictors I make at diagnosis. But what you're saying is the disease is more severe in terms of the immunopathogenesis and maybe the genetic burden, and the impact's more severe just because of having a chronic disease at that time in your life.
Yeah, it's a time where there's so much going on anyway. When you think, adolescence, all the changes that occur physiologically, psychologically, and to have to deal with a chronic disease at that time point when you're trying to really find your own sense of self, education, making choices about life. It's a particularly tricky time to develop a condition like lupus. So in terms of the treatment options, obviously these are very similar between children and adults, with the main difference being, even when something is licensed in adults, it takes quite a lot of time for it to then become available in children. Obviously, all the more standard DMARD type drugs are all freely available in children. but currently we only have one biologic, so belimumab, which is approved. Obviously, rituximab is used off-label, and there's no current use of adalimumab or other drugs, particularly in children. These are all still in trials. And this is one of the reasons why we're particularly interested in treat to target. So it would give us an opportunity to use existing treatments in a far more structured way to be able to control activity, hopefully earlier, in order to prevent damage and lead to improvements in health-related quality of life and survival. And this graph on the right-hand side is from that British Paediatric Surveillance Unit study, and it shows the treatments that patients in the UK are on at 1 year, with the green showing the current and the red showing the previous. And what I was quite surprised at looking at these data is, at 1 year, there was still 35% of patients receiving IV methylprednisolone. That seems quite unusual to me, and obviously high use of steroids in that first year. Mycophenolate mofetil is the most common drug, which is probably not surprising. About 30% of patients receiving rituximab, but that's in the face of all these patients still having methylprednisolone. So there is a bit of a disconnect there, and a suggestion that maybe we could be treating more aggressively with immunomodulatory treatment to try and reduce the steroids and the steroid burden.
Yeah, and there might be is it that the childhood form of the lupus actually requires a different range of therapies than what the adults require, or is it just we don't have enough data on the same range of therapies? And also the other thing I wondered when I saw that was whether our issues around things like adherence to long-term oral immunosuppressants causing there to be a greater reliance on intravenous, for example.
All that will definitely play into this, but I think also having a sort of assessment that you would use within the treat to target approach, where it's done every time, you're comparing visit to visit, you've got a sort of really firm hold on whether someone has improved, is stable, or got worse, and that could push someone to escalate treatment in a more timely way, so that we're not seeing patients on methylprednisolone at a year. So I think a big part of that is monitoring and introducing structured monitoring to try and move people along the treatment pathway quicker. So
you regard that use of methylprednisolone after a year, you regard as a kind of an indication of a failure of the sort of long-term maintenance therapies that should be preventing that from being
exactly. By a year, you should be trying to hit your low disease activity steroid target, if not lower. So, and this is something that, if we don't have targets, if we don't systematically monitor patients and measure targets, it's easy to underestimate disease severity. So this is some data that's been published by Eric Moran's group and from Monash, looking at patients who are not in LDAS, that 35% of them were misclassified as being in remission or low disease activity. So doctors are misclassified. So this is adult data, and I'm sure that this would hold true for pediatrics as well. But until you measure targets, and I've started doing this as part of my clinical care, so I now run a childhood lupus treats target clinic. Even for me, who I do look at SLEDAI scores and things like that, this is making a difference to my care and my ability to monitor patients more closely. So I think this is really important.
And do you think that patients underestimate the situation as well, that they sort of think I'm okay, when actually then when you assess things you conclude, well, you're not really on all your targets? Yeah,
I think potentially this is something that we run into quite a lot in lupus, particularly where people have got very abnormal bloods and we're worried as doctors and they're less worried, and obviously there's that aspect of just getting used to being unwell or having a bit of fatigue or having a bit of a rash. So I think it happens in both directions. So I think doctors can sometimes accept things that maybe they shouldn't be, and equally patients learn to sort of live with it and get on with it. And
or maybe they don't know what they should be able to expect.
Exactly. And I think treat to target is an area that, by actually telling patients about targets and telling them about what they mean, then it helps them to understand their disease better as well. So this is another abstract that caught my eye at EULAR earlier on this year, and this was a survey of biologic prescribing, so a fairly large survey across Europe, and within this they identified a subgroup of, out of 1,279 patients, 2 to 8 patients who were rated as physicians as being well controlled. But then when you actually look at these patients, they had a mean steroid dose of 9.4 milligrams per day, and they were experiencing flare, and some of them had SLE manifestations, which could actually be classified as severe. So there is this concern that actually just left to sort of, think about your patient based on just your clinical drug treatment and not monitoring something like targets and disease activity scores, that for a proportion, potentially up to about a third, we might be underestimating disease activity and not realizing that there is an opportunity to escalate care and to try and improve matters. So on the basis of all this, we've been really interested in developing a treat-to-target approach for children with lupus. And actually this came in as one of the top 10 priorities for paediatric rheumatology research across the UK in a prioritisation exercise that involved a whole range of healthcare professionals, but also patients, parents and charities, which was run across the UK. So this is something that we've been working on over the last few years, really. And to start with, what we did was look at data from the UK GESLE cohort study. So this is a national cohort which collects clinical and demographic data and also samples from patients across 24 sites across the UK. It's been running since 2006 and has somewhere around 750 patients in the cohort. And using this rich collection of data, we looked at if patients get into targets that had already been proposed by adult rheumatologists, does this have an impact on the risk of severe flare and also new damage? And we also looked at more descriptive things around, are these targets actually attainable in children? So we looked at 3 different definitions of low disease activity state and 4 definitions of remission. And what we showed was that the attainability was very similar to what it is in adults. And that attainment of all of these different targets, so all these 3 different low disease activity state and the 4 different remission definitions, led to significant reduced risk of both severe flare and also new damage. The other thing that came out of these data is that the risk of severe flare also reduced after 1 year. So again, highlighting that this first year is really important and that we need to try and really optimize our care during that first year in particular. The other thing that these data showed was that cumulative time in target is really important. So it's far better if you spend 20, 30, 40, 50% of your time in target than just a sort of one-off time in target. And this really significantly reduced the hazards of both severe flare and damage.
Yeah, and that's, very similar to what's been seen in adults, isn't it? And one thing I often think when I see this attempt to get on, because LL-DAS is an interesting target, because in rheumatoid, when we talk about treat-to-target, we talk about the DAS28, but in lupus, we include steroids in the definition of LL-DAS, don't we? So in some ways, you've got almost the different objectives slightly make war on each other, don't they? Because as you try to get the steroids down to get them in the target, you might increase the risk of disease activity going up or flares. But of course, damage can be related to steroids more than it's related to disease activity sometimes.
Exactly. So that's why, it's on purpose that these targets have been designed that way, that they take into account disease activity, they take into account steroid dosing, and they also take into account physician global, because none of these activity scores are perfect. So that's a way of mopping up any other types of disease activity that maybe aren't being captured fully by those scoring systems.
Yeah.
So very early in this programme of research, we actually did some qualitative work, so a qualitative study asking patients and parents about their thoughts on treat-to-target, particularly asking them about targets, what they thought would be the best type of target, asking them about the overall concept of treat-to-target, asking them if we should be targeting LDAS and remission, or whether or not they felt there was additional things we should be targeting. And we asked them about clinical trials and how we should be designing those trials. And overall, families felt that this would be a good idea. So this was a multi-site study, 7 sites across the UK. They thought that it would help them to understand the disease, particularly early in the disease, if they had this concept of knowing where they were trying to get to, if they were being told about whether or not they'd met the targets, if they hadn't met it, why they hadn't met it, the types of things that they were going to be working on together with the clinician. They thought that would really help to understand their disease, their treatments, why they were taking the treatments, and ultimately could help with compliance. Families felt that they would prefer to be entirely asymptomatic with no side effects. And this is an interesting one, because I've spoken to lots of different patients about this. So patients who are relatively new in the diagnosis, maybe in the first few years, tend to select a target of remission and want to be completely as they were prior to that. Whereas when you speak to patients who've maybe had lupus for 10 or 15 years, they've said things like, actually, I'd rather choose low disease activity state. I wouldn't want to set something too hard and not achieve it, and it might affect me psychologically. So it is something that is very much should be a personalized discussion, and could, different patients may want to choose different things, and different clinicians may also have their own take on it, especially for the initial target based on that patient's history and what's going on in the past.
Yeah, I mean, one thing I've often found, and I'm sure it must apply to children too, with adult patients when we've talked about this stuff, is as doctors, we kind of say, well, to us, remission means like there's no symptoms, there's no signs, and your medication doses are all stable and they're really well tolerated. And then the patient sort of brought up a load of other things and said, well, that leaves loads of other, there's all this uncertainty. I've got this chronic disease. If I didn't take these medications, I'd get ill. I have to take them. I'm dependent on them. Am I going to flare next year? All these other aspects about concepts of uncertainty and what should we do will become important, don't they?
And that's also important as part of shared decision making. And actually, when you're setting your targets, not just considering medically defined treatment related targets, also thinking about the wider context of the patient and their life. So linked to that, patients told us that they don't want us to just focus on low disease activity state and remission. They wanted us to also be thinking about health related quality of life. They particularly wanted us to be monitoring fatigue in a structured way, clinic to clinic, and suggesting interventions to help with that. And they also mentioned that how much they detest steroids, and that having steroids as a target and getting the steroid dose down would be particularly important to them. There were some concerns about the treat to target approach, primarily around, things like the increased frequency of hospital visits could affect schooling, could affect parental employment and finances. So I think when designing this approach and also studies, it's important to try and learn from things like the pandemic and our experience of remote monitoring and remote visits and things to make it work for the patient, whilst keeping it as effective as possible. So I think overall, I can say that patients and parents have been really enthusiastic about this approach. Some have said, compared to treat to target, standard care sounds rubbish. It's not rubbish, but I think it could definitely be improved. And I think that they were very positive about this.
Yeah.
And very much linked to this, we've involved patients and parents a lot in all aspects of this research programme. So one of the things that came out of that qualitative study was that the qualitative researcher spent at least 5, if not 10 minutes trying to explain the treat to target approach. So this is something that can be quite tricky to understand. And building on that, we went out to 3 different public patient involvement groups and worked with them to develop an animation which helps to explain this idea of treat to target and is lupus specific. And you can view that on YouTube, and you can also share it with any patients in advance of a treat to target clinic appointment to help them understand the approach a little bit before they actually hit the clinic room. And involvement of children and young people has been really important around thinking about the design of a future clinical trial. And we've also involved 3 young adults with lupus who are in their 20s who developed lupus as children in an international treat to target task force. So coming together with experts from around the world to give their views during consensus meetings. And there's been many, many times where what they have said has really impacted on the consensus process, where international experts have been at loggerheads and then the patients provided their view, and it's really clarified the way and helped us to see the wood through the trees. And some of these patients have gone on to become co-investigators in grant applications. So I think with this programme of research being so closely linked to patient experience and how their care could be delivered, it's been an area where we've had a really great opportunity to work closely with children and parents. So I touched upon the International Treat to Target Task Force. This is a group of around 20 professionals spread across the world, North America, South America, across Europe, Africa, Asia and Australia. who have come together, who are all interested in developing this treat to target approach for childhood lupus. We recruited them through the major professional organisations in paediatric rheumatology, and together, as our first task, we led a consensus process to develop principles and points to consider for childhood lupus treat to target. So this provides an overall framework for what treat to target should look like, all the things that it should include, considering targets, considering wider things that impact on care and also ability to reach targets, thinking about steroids. So there are 4 overarching principles and 14 points to consider. And there are very high levels of consensus in all these points to consider. This is a great document and a really great start for anyone who's interested in developing treat to target as part of their clinics. But there were a range of urgent research priorities that need to be fulfilled to try and help strengthen this approach further, with the top 3 being that we felt we needed paediatric specific targets. So there were aspects of the existing adult targets that we felt didn't quite fit for children. We wanted to look more closely at whether or not there's a dose-related association between steroids and damage accrual, because that could help impact on the sort of cutoffs that are included within the targets for different steroid doses. And we need to think about the optimal frequency of target assessment and actual escalation of care. So in terms of developing those paediatric specific targets, that was the second task of this International Treat to Target Task Force. So we reviewed all the existing evidence around targets in adult lupus, but also looking at paediatric cohorts that had looked at application of these targets. We wanted deliberately to keep the targets as closely as possible aligned to adult targets, to encourage life course studies, and for patients to be treated to target in childhood and for it to progress on into adulthood seamlessly. And what we have derived through consensus is 3 targets. One called the Childhood Lupus Low Disease Activity Slate, which is very closely aligned to the adult LLDS, which has been produced by Eric Moran's group. And then 2 remission targets, the CSLE clinical remission and CSLE clinical remission off steroids. And the middle one, the CSLE clinical remission, is very closely aligned to the single DORIS definition that has most recently been published. And the next slide just shows the main differences between the paediatric definition and the adult definition. So you can see for CLL-DAS, it's very closely aligned, with the main difference being that we've added in a weight-based steroid dosing. So whichever is lowest would be the maximum steroid dose that the patient could be on. So if you've got a patient that's 30 kilos, it would be inappropriate for them to be on 7.5 milligrams of prednisolone as a sort of maintenance dose. So that accounts for that. Similarly, with clinical remission, CSLE clinical remission, again, we've added a lower weight-based equivalent. And then we've added in this additional category of clinical remission off steroids. And there's quite a lot of reasoning for that. So, and this just graphically shows those 2 different definitions. So you can see clearly that there's 2 targets in adult lupus that are currently being proposed. And in childhood lupus, we're proposing 3 targets, with the 3rd getting them off steroids. So why do we feel as paediatricians that we need clinical remission off steroids? So the task force felt very strongly that we should be aiming to get patients off steroids. We know that they impact hugely on growth, on development, on puberty, and that patients detest them. And we know from adult literature, as we've mentioned earlier, that there's not really a safe low dose of steroid in lupus. So this first graph here is looking at damage accrual in patients who clinically have clinical remission, no serological activity, but are on steroids. And what you can see with, confidence intervals of 1.03 to 1.23 and a significant p-value is that is this one above here, is that the mean prednisolone, the time-adjusted mean prednisolone dose impacts on the likelihood of damage. And for every 1 milligram decrease in steroid dose, it reduces your risk of damage. So there's no safe, so from adult data, there's no safe lower dose of steroids. This is something that we want to look at in pediatrics.
Yes, I speak about lupus obviously quite a lot at different meetings and departments, and this is something I find quite controversial amongst different doctors, that I tend to sort of say it should be 0. It should only not be 0 if you haven't got any other options. But while you've got other treatments available, then you should be aiming for 0. But there's a lot of people who push back against that and say lowish doses are okay. They do prevent flares. There was a paper just out this month, which we'll probably cover on the Lupus Forum next month, I suppose, saying that you're more likely to get flares if you're on 0 than if you're not, unless, of course, the serology was all down, and then I think it's less of an issue. But it does seem. It seems like quite a controversial subject.
It is controversial. It definitely is a controversial area, and it is something that we need to investigate more in depth in paediatrics itself. But most paediatric rheumatologists would aim to get patients off. It's unusual that we would be happy to have someone teetering along a road.
That's my feeling too, and I always think it's a case of what other tools have you got to do? Have you really tried all the other tools you've got to achieve that? And then the other one being, how long is it? Was it before you started trying? As time goes on, it gets harder and harder, doesn't it?
And there's also data to suggest that in patients who you've got into remission, if they're steroid free, as opposed to being on 5 milligrams or less, that actually this impacts on mortality as well. So two big outcomes in lupus that are impacted.
And like you said, there's that big psychological effect. Steroids is one of the drugs you become most dependent on when you're on it long term, aren't they? Which is one thing that patients highlight. So I don't want to be dependent on these drugs. I want to feel like I've got control over it.
So for that reason, as a paediatric community, we've elected to have 3 targets. So low disease activity and 2 remission targets with the aim of getting people into clinical remission. So still not saying that we want to mandate serological remission, but getting them off steroids being key. So in terms of next steps, so this is, in November last year, we had an actual face-to-face consensus meeting. So prior to that, a lot of the work had been during the pandemic, and we'd been having online consensus meetings. And last November, we particularly focused on what a trial would look like. So thinking about inclusion-exclusion criteria, primary, secondary outcome measures, visit frequency, timelines for reaching targets, treatment optimization. And together we derived a clinical decision support tool to help treat to target. And also started some thinking around something called an interim trajectory score. So because you're not going to expect your patients to get into target in 1, 2, 3 months necessarily, we've developed this score that could help to tell you if someone is static, improving, or worsening, and that could also act as a trigger to try and do something before you're expected to have reached that target. So one of the things that I'm looking at within my treat target clinics is how this trajectory score performs. So in terms of next steps, what we really want to do is run a trial. So currently, with support from the Medical Research Foundation, I have employed a statistician who's helping to work through the different research questions that came out of the Principles and Points to Consider paper, working on validation of paediatric-specific targets, looking at steroids, looking at a number of other questions that will really help to shore up this approach and help to inform it. Following on from that, again, also funded by the Medical Research Foundation, we're going to bring together the task force again in Liverpool to run a Bayesian prior meeting. We think that we'll need to do a Bayesian trial because with lupus being rare in children, it's going to be really difficult for us to run a frequentis trial with like 400 patients per arm or anything like that. So this is our plan. And we're currently in the process of setting up a pilot that would run between Liverpool and Manchester, really thinking about the process of treat to target, any barriers or facilitators, how to streamline the process and make it easier so that the actual process isn't a hindrance.
And just for the people who haven't used these methods before, a Bayesian prior means that rather than a trial where you sort of act completely naively as if you didn't have any information to test your hypothesis, you take account of the information you already had. Is that right?
Yeah, so in this context, we would take into account any data that is already out there, primarily from cohort studies, but we might also be able to look at some clinical trial data sets. And we would also take expert opinion to form this Bayesian prior. You would use that to calculate your sample size for the trial. You would run your trial, and then the outcome of the trial would almost be like an update of what you knew from the Bayesian prior. So the results of the trial would not just be based on what happened in the trial. They would also take into account.
So I say, well, currently I feel a bit more than 50% sure that this is the better course of treatment, and what evidence do I need to get me up to 80% sure or 90% sure, isn't it? That's where
Exactly.
a much better thing to do when you've got sort of small samples and difficult questions, isn't it?
And it'll let us do a trial where otherwise we wouldn't have been able to do a trial because the numbers just aren't possible. So there is currently a trial, Lupus Best, that's been run in Germany, I think, where they've got 3 arms, 400 patients per study arm. There's absolutely no way we could do that study. And this is going to be something that's going to enable us to do a study that will provide more evidence than we currently have. And there are examples of this within paediatric rheumatology where small Bayesian studies have been able to actually change clinical practice. So MyPan, as an example, with polyarthritis nodosa, where it was an international study, I think it only involved about 15 patients, but it's changed practice and NHS commissioning. So I think this is a useful tool in rare diseases, particularly in paediatrics. So in summary, I think that we should all be trying to treat to target, because currently the outcomes that we have from standard care just aren't good enough. We now have targets, both in paediatrics and in adult lupus. We need to start using them. The impact of target attainment from observational data is really very positive. So we've seen, in paediatrics and adult lupus, that it's associated with reduced disease activity, damage, reduced healthcare costs, improvements in health-related quality of life. And it's really important that we get this right for patients and families, and also for clinicians, because everyone's busy. We don't want to overburden them. So we are doing a lot of work around trying to simplify treat to target processes. And that's maybe something that I can come back and talk to you about at a later date.
Yeah.
So thank you very much for inviting me to.
It's absolutely fascinating. There's so much there to think about what's different about treating lupus in children and adolescents, and some of the same lessons that we need to learn about treating adult lupus as well. I keep thinking, from what you were saying, that we need to get a bit away from this concept of just response all the time. We always say in trials, can we give a drug that will reduce disease activities up here, and can we get it down by this amount that sort of feels a bit better, is not really bringing in all the concepts and problems that occur in lupus. You really have to think of a trajectory, a course over time, all the sort of network of complications that come out of disease activity, not just disease activity itself.
And these are long-term studies, aren't they? So if you're thinking about trajectories, you're going to need a really long time to sort of look at them, and whether or not something like this could alter that.
Exactly. Like we always say like we said in rheumatology, like 15, 20 years ago, like if we got the first year right, would it make the next 10 years better? So when you're taking a disease that comes on below the age of 18, but it's going to have consequences for decades to come, those questions just get so much more magnified in their importance, don't they?
Definitely. I read you had a review recently which talks a lot about, we're using some of our most effective treatments later on, aren't we? So we need to be bringing these in earlier.
That's what I feel like when I see what I call the younger patients in my adult clinic, is I sort of feel like sometimes there are some people I know it's going to be bad, and we kind of just watch it happen. We're sort of chasing the disease rather than getting ahead. So I think this speaks.
So I think treat to target could really help to push people off the fence who are thinking, they're a bit better than they were last time I saw them. I'm just going to stick, or I'm not quite going to weed my step. This will help to sort of move treatment on, I think.
Yeah, we all know
in a structured way.
It's just making it simple rules to tell us to do them, isn't it? So that's absolutely brilliant. And unfortunately, it's all we've got time for today. But thanks for joining me, Eve. It's been really interesting to have your insights. And thanks to everyone for listening to this special broadcast that we've brought to you from the Lupus Forum. So as always, the Lupus Forum is free to access. All our content, including this podcast and all the PowerPoint deck associated with it, are free to download at lupus-forum.com. And if you register for updates with the Lupus Forum, then you'll get an email every time we have new content available. And you can also do that by following us at Lupus Forum, all one word, on Twitter and on LinkedIn. So thanks, Eve, and thanks everyone. See you next time.
Thanks a lot. Bye.